Mpox Masterclass. From zoonotic origins to outbreak control, everything you need to know. Welcome to the Mpox Masterclass. Once considered a rare, animal-linked virus from deep in the African forest, Mpox has stepped into the global spotlight, proving it can spread far beyond rodents and primates. In this lesson, we'll untangle Mpox's evolution from a quiet zoonosis to a public health emergency, with a focus on its virology, clinical course, treatment, and prevention. Let's get into the viral jungle and start decoding this poxvirus puzzle. What is Mpox? The basics. Mpox, formerly known as monkeypox, is a viral illness caused by the monkeypox virus, a cousin of smallpox, belonging to the orthopoxvirus genus. It first showed up in humans in 1970 in Central Africa and remained relatively quiet until 2022, when it burst onto the global stage, spreading across countries and communities in ways we hadn't seen before. From forests to cities. The 2022 global outbreak. The 2022 outbreak changed everything. This time, Mpox wasn't spreading through animal contact. It was traveling human to human, particularly through close physical and sexual contact, intimate social networks, urban centers, especially among men who have sex with men, MSM. It wasn't the deadlier strain Clade 1, but rather Clade 2, which causes a milder disease. Still, the virus showed it could adapt, persist, and disrupt, especially when it co-infected with HIV or other STIs. How the virus works. Virology and life cycle. The pox is a big DNA virus, large enough to be seen under a microscope and smart enough to dodge the immune system. It exists in two infectious forms. Intracellular mature virus, IMV, spreads from cell to cell. Extracellular enveloped virus, EEV, travels through the bloodstream and spreads further. The virus enters through the skin or mucous membranes, sets up camp in the cytoplasm, and uses the host cell's machinery to churn out copies of itself. It even makes its own replication factories and uses immune-dodging proteins to keep the body from fighting back. How Mpox spreads. From contact to outbreak. Mpox is spread through close, prolonged contact, especially touching skin lesions or scabs, contact with bodily fluids, especially semen and rectal secretions, contaminated surfaces like bedding, towels, face-to-face respiratory droplets, less common but possible. Also reported, vertical transmission, mother to fetus, needle stick injuries in healthcare, pet transmission, e.g. dogs. Mpox doesn't spread casually, but in the right environment, close quarters, skin-to-skin contact, it moves fast. What it looks like. Symptoms and stages. Incubation, 4 to 21 days, typically 1 to 2 weeks. Early symptoms, prodrome, fever, chills, swollen lymph nodes. Key clue, it's not seen in smallpox. Fatigue, headache, back pain. The rash signature feature starts as macules, progresses to papules, vesicles, pustules, scabs. May be localized, genital, perianal, mouth, or spread across the body, painful and itchy, with potential for scarring. In some, rash is the first or only sign, mucosal involvement. Proctitis, severe rectal pain, tenesmus, pharyngitis, urethritis, eye involvement, risk of blindness. Who gets it worse? Immunocompromised individuals, especially those with HIV and CD4-200, can develop necrotizing lesions, secondary infections, sepsis, or organ failure. Gold standard PCR testing, swab at least 2 lesions, ideally from different stages or sites, can also test oropharyngeal or rectal samples. Other methods, electron microscopy, histology, are rare. Serology? Not useful. Too much cross-reactivity with smallpox and other poxviruses. Always rule out lookalikes, herpes, syphilis, chickenpox, drug eruptions, treating Mpox, support first, antivirals when needed, supportive care, pain management, NSAIDs, opioids, topical anesthetics, hydration, wound care and rest, sitz baths, and lidocaine for painful anorectal disease. Antivirals for severe or high-risk cases, tecovirimat, blocks viral spread, taken with a fatty meal for absorption. Brincidofovir or cidofovir, DNA polymerase inhibitors, watch for kidney side effects. Vigiv vaccinia immune globulin, reserved for severe or vaccine-related complications. Resistance alert, tecovirimat resistance, mutations in F13L gene has been reported. Monitor treatment failures closely. Preventing Mpox, vaccines and behavior matter. Vaccines, JYNNEOS MVA-BN, non-replicating 2-dose vaccine, given subcutaneously or intradermally, well-tolerated and safe for people with HIV. Used for high-risk groups, MSM, sex workers, lab workers, close contacts. ACAM 2000, replicating live virus vaccine, higher risk of side effects, not recommended for people with HIV or skin conditions. Post-exposure prophylaxis, PEP. JYNNEOS, within 4 days of exposure, can prevent infection, can reduce severity if given up to 14 days after exposure. Behavioral prevention. Avoid close contact with anyone who has a rash. Use barriers during sex. Limit number of sexual partners during outbreaks. Infection control, stop the spread in its tracks. Isolation guidelines. Stay isolated until lesions crust, scab, and fall off. Revealing healed skin, cover lesions, wear a mask. Avoid sharing bedding, towels, or dishes. Healthcare PPE, N95, gown, gloves, and eye protection. Clean surfaces with EPA-approved disinfectants. Special considerations for high-risk groups. HIV-positive individuals, higher risk of severe disease, especially with low CD4 counts. Maintain ART and consider dual antivirals for treatment. Pregnant women, risk of fetal transmission. Tecovirimat may be used under emergency protocols. Children, rare cases, but when it happens, it can be serious. Prioritize JYNNEOS vaccination and close monitoring. Public health implications. More than just a skin disease. Mpox is not a gay disease. Anyone can get it through close contact. Combat stigma while promoting testing, vaccination, and treatment. Surveillance matters. Watch for Clade 1 importation and monitor vaccine breakthroughs. Quick recap. What you need to remember. Mpox spreads through close contact, especially skin-to-skin and sexual contact. PCR testing from skin lesions is the best diagnostic tool. Most cases are mild, but severe disease can occur in immunocompromised patients. Supportive care is key. Antivirals are reserved for serious cases. Vaccination with JYNNEOS protects high-risk populations. Isolation, PPE, plus hygiene are critical for controlling outbreaks. You did it. You're now Mpox-wise and ready to lead the response. From skin sores to stigma, from pox to prevention, you've got the knowledge to diagnose, treat, and protect. Would you like this